Welcome to the screening, referral, and follow-up autism spectrum disorder using the MCHAT-R. And welcome to all of our off-sites at Mid-Central AHAC in Mount Pleasant, Michigan, Southeast AHAC in Detroit, Michigan, UP AHAC in Marquette, Michigan. I would like to just couple reminders. There's an evaluation form in your folder. If you would please complete that and leave it with us before you sign out. If you're getting psychology continuing education, there is a sign out sheet, time in, time out sheet at the front. If you would complete that before you leave. CMEs, there's a couple that would be for disciplines, MDs, DOs, NPs, RNs, PAs. We will have you sign out and hand in your forms on the way out for the CME credit. And I would like to now introduce our speaker who drove here this morning, Friday morning, all the way from Detroit. So let's welcome Michelle Fuhr. She is a BCBA, the Supervising Behavioral Consultant for the University Pediatrician Autism Center at Wayne State University. So thanks for being with us today, and I will turn it over to you.
Good morning, everybody. Thank you for coming, and thank you for your patience this morning as we get settled in and finalize last-minute things. So today I was asked to present about the MCHAT, and it's a screener for autism. And as we know right now, autism is drastically increasing, right? We've probably all heard, seen things on Facebook, the news, et cetera, about different causes and speculations of autism, as well as the astounding numbers. When I started in this field, the numbers were 1 in 150. And now the numbers are looking more like 1 in 62, 1 in 63 kids. So the numbers are really increasing over time, which presents to us that we need to educate ourselves about what this diagnosis is and how to treat this diagnosis. So my end of services is a little bit more on the treatment end. I'm a board certified behavior analyst, and as part of that, I provide treatment to children on the autism spectrum. So we work on, for example, behavior problems and behavior reduction. We work on skill building, such as social skills, communication, toilet training, sleeping issues, et cetera, and really incorporating the parent component of how do we now get parents to implement treatment, and how do we get parents to make changes in their lifestyle in order to really foster the growth of this person with autism. So I'm kind of speaking from that end a little bit today, but I did want to educate you guys about what this screening tool is and how to use this screening tool. So here's our agenda for today. We're going to talk about that screening for autism disorders and what the necessity is. We're going to go over a review of the MCHAT. We are going to talk about the administration and scoring. Now this is going to be the largest piece because this is the piece that's really the most relevant to you guys, right? This is the piece you're going to be practicing. We're going to talk about some considerations and concerns of using this tool and of working with parents, and when you're presenting this information, what are some things you might run into. Referrals and recommendations. So now the next step, once you have that red flag for autism, what do you now do with that information and how do you refer? And then we're going to talk about, once that referral is made for the evaluation, how do we now coordinate care? How do we now follow up? How do we ensure that the parents have actually followed through with our recommendations? So your learner objectives today, you're going to be expected to identify the signs of autism in at-risk clients, identify the importance of this early screening. Why is this so necessary, and how does this really help us in the big picture? Implement all the components of this MCHAT with the guardians of at-risk children. Score the MCHAT to determine the proper responses and referrals that you would make in response to their scores on the MCHAT. Refer to the next steps of treatment, or for treatment or evaluation. So we're going to talk about when each one is the most appropriate and how to do that. And then follow up with clients and providers to determine that follow through, like we mentioned before. So autism spectrum disorders is a developmental disability. How many here are somewhat familiar with autism? You've seen it, you've heard of it, you know the symptoms. Excellent. So these next couple slides will just be a nice review for you. So it is a developmental disability, meaning that children in this category are typically pretty delayed compared to their peers, and it's kind of in that category, an umbrella of developmental disorders. There are 3 primary areas of improvement. So we're looking at impairments in language, so communication delays, and autism is a spectrum disorder, so it can look very different depending on the client. And sometimes that person is extremely impaired in a certain area or in all areas, and sometimes they're actually really only mildly impaired or mildly affected in these areas. So the three areas would be the communication, social interactions, and then restrictive and repetitive behaviors and interests. And so a child who has a higher skill set with some of these things might look like somebody who can communicate fairly well, but maybe has a hard time holding conversations or talking about a variety of interests. They may be socially awkward, so they may say the wrong things or not know how to really make good eye contact and interact with you at an age-appropriate level or a developmentally appropriate level. Restrictive and repetitive behaviors or interests might be things like they're hyper-focused on a certain, Spider-Man. They're obsessed with Spider-Man, or they're obsessed with Star Wars or something like that, and it's all they want to talk about, that's all they want to play with, that's what they really want to do. At the other end of the spectrum, we have kids who are more significantly impaired, and so those kids may have no language at all or very minimal language. They may have extremely restricted social skills, so they may not know how to socially interact at all. Some kids want to be a little bit more isolated. Others are wanting to be social but don't have the skills and abilities to actually have those appropriate interactions. And then we have the restrictive and repetitive behaviors on that end. So some of these things could look very stereotypical, like hand flapping and rocking. Those are very common or very stereotypical kind of autism repetitive behaviors. But again, sometimes this is just restricted interest in a particular toy or a particular TV show or things like that, even at some of the more impaired ages or impaired end of the spectrum. Autism is currently 1 in 68 children. Like I said before, when I first started in the field, it was 1 in 150. So it is drastically increasing, and part of that is the awareness and our evaluation and assessment and diagnosis of this. And it is more prevalent in boys than in girls. So there is a lot of medical research going into some of the genetic rationale for why this is occurring and why it is more prevalent in boys than in girls. I wish I had a definitive answer to give you today, but I don't. So we're going to leave that to the medical professionals to keep doing their work and trying to find that reason. So the American Academy of Pediatrics does have some specific recommendations for autism. So they want us to do these developmental surveillances at their well-check visits. And kids do receive well-check visits every couple of months as they're growing up. I have a 3.5-year-old daughter, and I tell you, it's like you're constantly at the doctors for well-check visits and things like that, which is actually really great. But part of the goal of that is to elicit the parent concerns and find out, weed out, is there any concern for autism or other types of developmental disabilities or other types of concerns. So those screenings happen typically at 9, 18, and 30 or 24 months. And it's important to think about how to incorporate this screening tool for those of you guys that are in the pediatric field, how to incorporate this screening tool into the well-check visits as well. And then there's the recommendation for the screening at the 18 and 30 or 18 and 24 month visits. So we're going to talk about why specifically at those visits with regards to how the children develop and so forth and what should occur. So the screening is extremely important because screening leads us directly to referrals. If we know earlier, if we can diagnose earlier, if we can catch this earlier, the gap that the child has compared to their typical peers of differences in their development is much smaller when they're younger. So that gap becomes much bigger over time as their peers grow at a much faster rate than they do. So the earlier that we can catch this, the better it is for that child's success in treatment. So if we can get them screened earlier and recognize this earlier, then we can get them into treatment earlier and refer them to proper services. Again, depending on where the kids are at in terms of their abilities and their level of impairment, that level of services might be really intense, or it might be something that's just getting them some extra supports at school and things like that. But either way, they would be able to get some extra supports in order to help, bridge that gap, close that gap a little bit more, and then potentially, recover from autism. That's an option. It's very few and far between. Or to just really improve their quality of life and really improve the parents' quality of life. One of the things, again, as a clinician looking at this is when I see kids who are 20 years old and are, have just now received a formal diagnosis because there wasn't really quality referrals before, there wasn't really quality recognition of the symptoms, and we've gotten better over the last few years now that autism insurance has passed in Michigan. So we've gotten better at kind of recognizing autism and the importance of this, recognizing this, the symptoms of this disorder. But before that, we have now these kids in the system and adults in the system that are 20 plus years old that have gone without services. And at that point, many of them have extreme behavior problems, and they have a long history of behavior problems, and they have a long history of no communication, no abilities, no communication systems, and so forth. And it's truly a sad picture, because if we can catch those kids much earlier and educate the families on what they need in order to provide adequate services and improve their quality of life, reduce the likelihood that they need these intensive treatments and they will have these long-term behavior problems, and then also make sure that they have treatment so that way they are getting their needs met. So it's so important to really think about how can we improve this person and the whole family system by intervening younger when it's quote unquote easier than when they have this long history and have gone without for so long. I'll tell you, at the time that the kids are, or the adults are in their 20s, 30s, and plus, parents are often experiencing pretty severe burnout, when you're talking about some of these more severe cases. So it's a lot easier to manage a 2-year-old than it is to manage a 22-year-old or a 42-year-old. So that really leads as well to better outcomes. That early intervention does get us more progress, and it does get us better outcomes in treatment for all those reasons that I was just kind of talking about before. So we do have some research here from McDonald that there was children in ABA at ages 1, 2, and 3, and all children made significant gains after 1 year of ABA, but those who were enrolled before age 2 made the greatest gains. Now, age 2 is extremely young, and right now an early diagnosis is like 2 years old. But if we can catch these kids even earlier, and it is happening. There are differences that research is recognizing even in infants right now. If we can start recognizing those differences earlier and starting to identify these risks earlier, then we can start getting these kids into treatment by the age of 2, and then really impacting that quality of life again, really closing that gap when that gap is much smaller. Other risk factors that are really important for you to be aware of is that siblings with an autism diagnosis increase the risk for another child with an autism diagnosis in that same family. I've worked with families that unfortunately have multiple kids on the spectrum, and those parents are just burnt out a lot of times. They're overwhelmed. There's a lot going on in those families, and so those kinds of factors do increase the risk for the next children to have other kids with autism, or the parents to have the next generation of kids with autism as well. So those are really important factors. Also, certain genetic or chromosomal disorders. So if you're seeing a family that has Down syndrome, Fragile X, tubular sclerosis, or other genetic conditions, those are also flags that there's more likely to be a child with autism in that family as well. So kind of something else, if you're seeing those characteristics within a family, you might want to kind of make sure that your radar is a little bit more heightened on that family to see if they do have the necessity for screening of autism. Premature birth also increases that risk of autism, and then older parents at the age of conception. So for mothers, this is greater than the age of 35. Typically at that age, mothers are considered more of a high-risk pregnancy for many reasons. And so we do tend to see higher risks of autism. And then if the father's age is above 40 at the age of conception, we also tend to see that correlated with higher risks of autism as well. If you guys have any questions at any point, just jump right in, ask me, let me know. So getting to the MChat. Like I mentioned before, this is a screener tool for autism, and it's pretty simple. It's a questionnaire. It's 20 questions. It's yes or no for the parents. Of course, parents can always skew the results a little bit if they're concerned about their, child being diagnosed, and we'll talk about how to manage that later on in this presentation. But there's like 20 yes or no questions that they have to just pretty simply fill out. It measures social reciprocity, language, and some motor skills. So again, we're looking at that social skills because remember that was one of the qualities that was a symptom for kids with autism. Also, language was also one of the areas for impairment of kids with autism. And motor skills may also indicate some level of delay as well. So we want to look at all three of those areas to kind of ensure, are we really wholeheartedly and well-roundedly kind of catching those risk factors. Typically, it's given at about 16 to 30 months of age for that child. Younger than that, some of the kids may not be able to do these things because developmentally they haven't achieved those milestones yet. And then older than that, they should be able to do these things, but at that time, some of these skills might be more, quote unquote, like infantile for them, you know. And it detects autism, language impairment, and intellectual disability. So we're kind of hyper-focusing on autism with today's presentation, but this is a screening tool that may catch some of these other things as well. And when we get to the referral section and we talk about, you know, possibly referring when the person doesn't have autism, well, this is not a diagnostic tool. So there's further assessments that are going to need to be done that actually confirm which classification and diagnosis does this child actually fit into. But this is at least a starting point, and it will at least show us that there are some red flags in these general areas, and that the next person, that the psychological evaluator, would be able to kind of definitively identify which of those diagnoses is more appropriate, if any. And then these are the women who developed this: Diana Robbins, Deborah Feen, and Marianne Barton. This is really a tool that can be administered by nearly anyone with training. So we have a pretty wide array here today of clinicians and social workers, nurses, people in the medical field, people in the psychology field, and so we have a pretty wide range of people that can administer this. It's not something that you have to be extremely highly trained in, but you know, with today's education, you and I both will be able to administer this and, you know, feel fairly confident with the results that you're getting. I've also included on each of these slides that I have a reference. There's the website in the link below, and at the very end of the PowerPoint there's a list of references, but definitely when you get a chance, check some of those references out because they've been really amazing tools for getting some further education on this screening tool, as well as I'll show you in the end, there's like some links for, you know, being able to translate this into different languages and doing online MChats and things like that. So again, here's some of those websites of where you can get a free download of the MChat. We're actually going to send you a link at the end with the MChat and the manual and everything included in that for today. But this is what it looks like. It's 20, here's only 5 of the questions, but it is 20 questions. And you can see something here. It says, if you point at something across the room, does your child look at it? For example, if you point at a toy or an animal, does your child look at the toy or animal? Yes or no? So most parents would be able to pretty confidently answer a question like that if they, you know, are interacting with their child pretty frequently. So they would be able to say, yes, they are, or no, they do not respond in that way. So that would be a red flag. This would be considered more of a social skill within the autism domain to try to figure out if there is something that they are like referencing, if they are attending to people and so forth, and if that may be a little atypical. Have you ever wondered if your child might be deaf? Yes or no? So many kids with autism, they may seem like they are hearing impaired. And the reason why is because they may not attend and respond the way that a typical child would. So when they're given an instruction, because of their communication and their social delays, they may not understand the instructions or they may not know how to respond to those instructions. So the parents often question, is my child deaf, or does my child have a hard time hearing, or even is my child just very non-compliant because they only do it when they want to do it, or things like that. So they may sometimes wonder if their child may be deaf, depending on their child's skill level. Does your child play pretend or make believe? For example, pretend to drink from an empty cup, pretend to talk on the phone, or pretend to feed a doll or a stuffed animal. Now these really simple pretend play skills and imitation come in at very, 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 very young ages. It's amazing to me how young some of these kids are, you know, walking around on their cell phones. They can't even talk yet, and they're blah, 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 blah on their cell phones and stuff like that because they're imitating the social cues and the social things that people around them are doing. So if they're not doing those things, that would be a red flag for autism. That would be, again, that impairment in social skills. Does your child like climbing on things? For example, furniture, playground equipment, or stairs? So that would indicate more of the motor skills and so forth, and exploration. Again, many of our kids have really restrictive interests, and they're not exploring their environment to the same extent that a typical child may. So we might see some impairment in those things as well. Does your child make unusual finger movements near his or her eyes? For example, does your child wiggle his or her fingers close to his or her eyes? So it might look something like this, or just looking past their fingers. So that might look like more of those stereotypical restrictive and repetitive behaviors in that category. So some of these behaviors, like this example, I've worked with numerous clients. I mean, probably the majority of my clients don't necessarily do this, but that is something that many people kind of stereotype and classify into an autism diagnosis. So if they're like, no, my kid never does that, don't be like, oh, okay, they definitely don't have autism. Yes?
So for a question like that, if a child does, like, flap their hands, but it's not here,
Yeah.
that to me is a different question.
Yes, I agree.
You would still say no, even though they have hand flapping.
Yep. Yep, so you would say no. So if they're hand flapping lower and not in front of their eyes, this would be a no to that question then. And then you would then, that might be additional information that you collect as the clinician evaluating and screening this, but this specific question would still be a no. Okay. Yeah.
Do you have a sense of, because it's not captured on there in any other way, do you know, like, why they didn't look at that as a symptom?
I don't know why they didn't look at that as a symptom and why they didn't put it on here in a different way, but I think that, again, in my experience, autism can look so different. And I have had kids who don't necessarily engage in very stereotypical hand flapping behaviors at all. And so it may not be on here at all. Unfortunately, in 20 questions, I don't think we can capture everything, but I think we can capture what is kind of the stereotype and like the overall similarities with kids with autism. Okay. So, so now when you go to this website, and today you'll be getting a few of these, again, emailed to you, but there will be scoring guidelines. So there's a really nice manual that Diana has developed, the creator of this, and it really walks you through how to do everything. So in the future, if you have questions, it's a really nice tool to reference. And it gives you kind of the guidelines for how to score certain things and how to determine, where does the child really fall on this question? Should this really be a yes or a no? And then also within that manual, it gives you flow charts, and we're going to go over some of those flow charts today and how to use them, but it does give you some nice flow charts of, like, if the parent says no, follow up with these questions, and then these might be some, common answers, and this is how you would score those responses. So here's kind of my flow chart on the process of how this goes. So starting with gathering parent concerns. So depending on what your role is, if you're a social worker and depending on where you work in social work, if you're in a school or if you're in a hospital, your role is going to be slightly different. If you're a nurse, your role is going to be different. So each of you kind of have to frame this in terms of what your role is and the placement of your job. But at some point, you're gathering some kind of information. Maybe that's coming from the pediatrician directly, or maybe it's coming from you when you're checking that client in at the well visits and things. But you're going to gather information about, does the parent recognize that there's any delays? Does the parent see any kind of concerns? And a lot of times the child is typically present during this, so you're going to kind of keep your eye on the child to see if you're observing anything. And anything that may seem odd or may seem like it fits into one of these categories of autism. And then if you have those concerns or it becomes standard practice at your practice, then you would provide the parent questionnaire. We're going to go over that today. That's the one that we just looked at, the first 5 questions. So you're going to provide that parent questionnaire, give them a few minutes to score it. They're going to score it all yes or no. Everything does need to be answered on that. So if they come back with something blank and they're not sure, then you would have to follow up and make sure that all those questions are completed. From that initial questionnaire, you're going to evaluate their level of risk. So we're going to go over today what those 3 levels of risk are and how you would respond at each level. But that initial questionnaire does give you the opportunity to evaluate kind of, where does the parent perceive the level of risk? Now that may be different than your perspective of the level of risk, and we're going to talk about how to respond to that. The interview, then if they're, depending on what the level of risk is, so if it's a medium level of risk, then you're going to follow up with the second portion, which is a parent interview. And you're going to ask the questions that the parent failed the client on in the first questionnaire. You're going to follow up and ask those questions. and be able to gather some more information, make it a little bit more discussion-based, be able to gather some nice information about, the client profile and, how things are going, and really be able to kind of decipher for yourself where the client or patient should actually be scored at. And then if from there they screen as positive or you have enough concerns to move forward, then you would discuss the results and you would make the appropriate recommendations and referrals for further evaluation and going into diagnostics and treatments and so forth. Any questions on this process so far? We'll go more in depth of these steps as we go. All right, so starting with that parent questionnaire. So at this point, you would have already gathered information. You would have already discussed with the parents, some kind of, is there a concern for autism? How is his language? How is his social skills? How does he interact with people? And then moving forward with the questionnaire here. So when you introduce this questionnaire, you're going to have to give it some background, right? Instead of just slapping a questionnaire in front of the parent and be like, here, fill this out. We want to educate our parents. We want our parents to know what they're being asked to complete and why they're being asked to complete that. So introduce the questionnaire, kind of explain why you're giving it to them. So maybe this is just standard practice. Maybe it's, he's 18 months old, this is his 18-month-old checkup, so we just do this as our standard practice at 18-month well visits. Or it may be partly because of risks that the parent reported. So maybe they said like, oh, I have these other kids with these other diagnoses in my family, or, I have a diagnosis of such and such. Then those might be additional risk factors that you may want to also say, because of these risk factors, we want to follow up and make sure that there's no further need for evaluations due to risks that you observed. So you may have, when you're observing the client, have recognized that maybe they're not socially interacting, or maybe their brother has come up to them 5 times and you see them turn away from their brother and just continue to play independently, and it looks odd, it looks atypical. And so that might be a red flag to you, or you see that you've tried to interact with them and they're not responding in a typical manner. So many kids, when you try to interact with a child this young, they may shy away, they may coddle into their mom, but they're still going to maintain some level of eye contact with you. They're still going to show you that they're aware that you're there. A child on the spectrum may shy away or may go into a corner or may not react to you at all. So they might just play with their toys just as if they were before you came up to them at all. Or they may not have the language or abilities to respond to you. So those are things that you would want to kind of assess when you are doing the observation piece. So if you've observed some risks, then that would be something that you would follow up with. Again, if it's standard practice. So I would love for this to become just part of our standards of practice, and that all of our clinicians and all of our pediatricians would be doing this as part of their well-check visits, and we would just be doing this at typical patterns, so that way it becomes something that we can catch more kids who, again, not just meet the criteria for autism, but language impairments and developmental delays and so forth. We can catch those kids better and get them the support that they need. So I'm going to show you guys a video of what administering this questionnaire would look like. This is Harris. Today I'm going to have you fill out the MCHAT. The MCHAT is a autism screener, or also a screener for other developmental disabilities. We'll let you know if there's any red flags that pop up on this. Basically today, all I want you to do is just answer each of these questions really honestly. It's 20 questions. It shouldn't take you too long. Each question you're going to say yes or no to. I need every question answered because I'm not able to score it unless every question is answered. So please just score whatever she usually does, as whether she usually does it or does not usually do it most of the time. That will be helpful. If you have any questions, we can talk about it, but just try your best. The reason why we're doing this today is because it is Gemma's 24-month checkup, but also you mentioned some red flags about her social skills, and she's not really communicating the way that you would expect for her to. So I just want to see if there's any other reason for concern, and then when you're all done, I'll come back and we'll go over it, and after I score it, we can see if there's any other reason for concern. Okay? Okay. Any questions for me? No. Perfect. All right, well, here you go. Obviously, very planned out, right? You guys aren't going to be quite as robotic and planned out when it's real life, but just to at least give you guys a glimpse of, what that initial rationale might look like in introduction, giving them some level of background, giving them some identification of the things that I identified that were concerns and risk factors, as well as it, just being standard practice. And, do you have any questions, opening up that opportunity as well. Some parents, bless you, some parents are going to be very resistant to giving out accurate information on a questionnaire like this. Some parents are extremely guarded and concerned about getting a diagnosis. So they may at that point refuse. They may at that point say, you know what, no, I'm good, thanks, or, I don't have any concerns for my child. I'm not sure why you do, and let's just move on. Okay, so you may have to kind of work through some of those kinds of concerns at that point and saying, well, tell me about that, and what are your concerns with getting a diagnosis, or what are your fears about completing this questionnaire? And start communicating with them about their perspective. And you may be able to make some progress. Of course, parents do have the right to deny, moving forward with screening questionnaires and things like that. So they may deny it, and you may not be able to get that information, but you have to determine then as a clinician, do you have enough information to still move forward with a recommendation for an evaluation or not? Do you want to follow up at the next visit and see how things are going before you make those further recommendations? So after that first questionnaire, you would score your questionnaire, and questions of 2, 5, and 12 would all be scored as a yes. Everything else, 2, 5, and 12, a yes would indicate that they have a risk for autism or one of these other diagnoses, but everything else should be scored as no. Okay, so it's pretty easy visually to kind of see, the scoring, and I will show you an example on the next slide as well of what that would look like. If the patient scores at 0 to 2, that would be a low risk of autism. Okay, so you may see like some kids, yeah, they're 18 months old and they flap their hands periodically by their face or things like that, but may not be enough of a concern to really say that this child needs an evaluation. So moving on to, depending on their age, if they're less than 24 months and they're in that low risk range, so they do get a couple scores, but not anything really significant, you might want to reevaluate at their next visit, okay? So maybe you did this at their 18-month or their 9-month, or I'm sorry, not their 9-month because that would be too young, but their 18-month, and now you want to follow up again at their actual 24-month. But if they're older than 24 months, then you might not need to do anything moving forward unless there's other risks, like if you've maybe the parent underreported things. So maybe the parent scored them as gave a score of 1 or 2, but you have additional concerns and you have additional things that you saw and you observed or that the parent verbally reported to you, and you kind of feel like, you know what, there actually might be more of a risk here than what the parent is reporting on the actual questionnaire. Then if you have those concerns, you would still move forward with the evaluation and referrals. If there was no further concerns, then you would take no more action. Okay, great, you scored great, everything passed, I have no concerns, you're not reporting anything concerning, no need to do any further evaluation. Everybody clear on that? Okay. So if they score a 3 to a 7, that would indicate a medium level of risk. So those are the times where you want to do that second portion, which is the follow-up interview, only on the remaining questions that they have failed. So those 3 to 7 questions that they actually failed. Those would be what you would do the follow-up administration on in the follow-up interview. And then lastly, if they score a 8 to 20, that would indicate a high level of risk. Basically at that point, because it's such a high level of concern, there's no need to do a follow-up question. We're just gonna move forward with the recommendations for an evaluation and referral. So we definitely see a lot of concerns, okay? Any questions on any of these 3 areas in your responses? No? Okay. All right, so what we have here is the questionnaire, and I know it's really hard to see because it's on one slide here, but this would be the questionnaire that Mrs. Harris in our video that she completed after I asked her to complete that questionnaire. And so you can see all 20 questions. It's just one page. It's just one front of a page. It's not a very long questionnaire at all. And you can see the ones, remember 2, 5, and 12 would be scored as no, and those would be appropriate to be scored as no. Everything else should be scored as a yes. So if anything else is scored as a no, that would indicate a red flag, right? So the ones that I've circled would indicate a red flag. So based on this, what would Mrs. Harris's score be? A 5, right? Pretty easy. So based on it being a 5, where would she fall in terms of risk? Medium risk. So what do we need to do? Follow-up interview. Guess what, right? So we're going to go through then with the follow-up interview. So in the follow-up interview, you're going to discuss each of those failed questions. And you're only going to do this with that medium risk, okay? Of course, as a clinician, you might have to use your clinical judgment at times outside of that medium risk time, but that's kind of what, the standard of this assessment tool is. Only when there's medium risk. So you're going to follow up on those failed items, and there's a follow-up scoring sheet that you would use that basically gives the same exact questions, but it says pass or fail instead of yes or no. And it says at the very top that it's a follow-up scoring sheet. And again, all of this is in the manual, all of this is on those online websites, and you'll get copies as well at the end emailed to you. So you would use that follow-up scoring sheet. And in the manual, there's also the flow charts that we're going to go over, and I will show you a screenshot of what that looks like as well in a few minutes. But those flow charts will help you to identify like how to respond and how to ask each question and what types of answers you're looking for. So can anybody tell me why we might do this kind of interview? What would be some of the benefits and the reasons why we would do a follow-up interview like this?
To give more information and give more examples of what the question's intent might be.
So for you to give more information about the questions? Yeah, and the rationale behind the questions and the intent?
It seems like, some of the questions, even though they're yes or no, there's always subject to interpretation, and
Yeah.
like, 50% of the time, or does it mean this or that? And I think sometimes just explaining it
Yeah.
means, it's like, I didn't get that you meant that.
Yeah, so removing some of that interpretation error and trying to really kind of get to what is the question actually asking and allowing them to respond. Yeah. Any other reasons? Yeah.
Even just the back and forth response with a parent
Yeah.
helps build rapport.
Absolutely. Building rapport back and forth. It's so important, especially at these stages, because remember, many parents who are going through this process, this is pretty fragile, right? I mean, they're...
Offsites can't hear when you're asking questions.
I've been reiterating.
Oh, perfect.
Yep, I've been hoping to reiterate. Yep. So that's why I've been repeating what you guys are saying, if you're wondering. But so, anyways, yeah, the rapport building is so important because they have to, they're really fragile at this point in time. Many parents may have some concerns, and they don't know what to do with their own child. How difficult is that? I mean, I have this child that I envision this life with, and now all of a sudden, as my child is maturing, they have skills or skill deficits that I don't know how to react to. As a parent, we want to feel confident as parents. So this parent may be coming to you feeling maybe ashamed, maybe a little bit broken, maybe a little bit like they're having a difficult time bonding with their child. Other parents are kind of at the other end of the spectrum where they're feeling a little bit more guarded, and they're feeling a little bit more like my child is fine. There's no reason to do some of this. So that conversation definitely helps to build the rapport and definitely helps you get more accurate information then as well. Any other reasons why you guys might think an interview would be beneficial?
I just have a comment.
Sure.
I know when clinicians and medical doctors state the fact, it's black and white, but also put in there the humanity when you're talking to the care. It's almost like you have to have that emotional. I'm saying this because I have a child who is 21. He has autism, and when they gave me that diagnosis, this is your child, bang, 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 and there was no softness or caring, and you're just black out. And I did not hear anything after that.
Yeah.
So the follow-up interview is so beneficial. for me to understand what has happened.
Yeah. So it really makes it more personable.
Yes.
It makes it more personable. It makes it more emotion-based rather than feeling so black and white and let's just get you patient in, patient out, check you off the list. Here you go. Here's your evaluation. Right. Definitely. Definitely. I mean, I will say a lot of people in the community feel that way about a lot of interactions with clinicians such as ourselves because we can be very, cold, I guess, sometimes, where we have, huge agendas, back-to-back clients, busy schedules and everything, and we got to keep moving, got to keep going, right? We're very busy people, and we have to remember that when we walk in that door, that patient is our number one priority, and we have to have them feel that way in order to help create that bond and in order for them to open up to us and for us to really be effective with working with them, meeting their needs. That's why we're there. So it can be difficult to remember that, but we need to keep that in mind as well. So that goes back to a lot of that rapport. So we did talk about the less interpretation error, as well as this gives the clinician the opportunity to ask for more clarifying information. So again, especially in those times where you're feeling like, what they're saying is not lining up with what you're seeing, those are times where you're like, tell me more about this. Tell me a little bit more about what's going on. Can you give me some examples of this? Let's really talk about and discuss this rather than just feeling like I'm coming in to fill out a questionnaire, right? Making it, again, more personable. Seeking more specific examples or information, as well as the clinician, you guys really receive more information about the client because it becomes more discussion, and then you're allowing the parent to really open up about all facets rather than only the things that you are trying to identify, right? So you're kind of having a discussion, and it should come off that way to the parent as a more lax conversation rather than you have a giant agenda, let me just go down my checklist. And then again, because we're receiving more information, then we have more information to make better decisions with. So now I can make better decisions on where I'm referring this client to and how I'm referring this client. Maybe I just found something out that I need to report back to the pediatrician or to my supervisor that is a concern or a red flag, or I'm calling CPS instead of calling an evaluator. I mean, there's a lot of different reasons why you may have to get more information about what's going on. All right, so here are those lovely flow charts that I mentioned. So the initial question here, just going off of question number 1, you would ask the parent, so if you point to something across the room, does Johnny look at you? And then they would respond yes or no. Yeah, he looks at me. He looks at me all the time, yeah. And then so they say yes in this example, then you would respond with, give me an example of how he would respond if you point across the room. And then here's some examples that the parent might give that you would respond as yes or no. So for example, he looks at the object. I tell him to go, hey, Johnny, look at that. And he looks at what I tell him to. Or he points to the object, or he looks and comments on the object, or he looks if the parent points and says, look. So those would all be past examples. And then if they said no, then you would respond with, so what does he typically do? So if you point at something and he doesn't look, what does he do instead? And then some fail examples might be like, well, he just ignores me, or he doesn't pay attention, or he just keeps doing what he does. He looks around the room randomly, or he looks at the parent's finger. So he's not paying attention to that social cue of where do I look? You're kind of, when you point at something, you're kind of following this like imaginary line, right, across the room to whatever. And it is a really big attending skill for our children to acquire that many children on the spectrum are either missing completely or delayed in. And so this is a really important skill to evaluate. So if they said yes only to the pass examples and gave at least one of those examples, then you would pass them. If they said yes to only fail examples, then you would fail them. But if they're giving examples of both, well, sometimes he ignores me and sometimes he looks. And then you're like, okay, now which one is it? Now, if they does both, then you would ask a follow-up question like, which one does he or she do most often? What do you see him usually do? Okay? And that's what you're trying to get at, is that more often than not, because sometimes as parents, we always look for hope. right? We want our kids to be progressing. We want our kids to be doing well. So we want to look for the times where they do it. And those are the times that we want to report on to others as well. So when they say like, yeah, he looks across the room, sure, he's done it before. Okay, but how often does he do that? Does he do that every time, or does he just do that once in a while? So trying to get that frequency. And then if they say more often, then that would be that they pass. And if it's less often, then it would be that they would fail this. Okay, so these flow charts and diagrams are extremely helpful. Again, you don't have to use this exact precise wording, you know, but at least gives you an idea. And when you first start using this, you might want to use this exact wording so that you get yourself kind of comfortable with the questions and the process. But then over time, you may want to start modifying it so it meets your needs and it kind of fits with your flow at the same time of making sure you're getting the right information and accurately actually assessing. Now, I will tell you, one of the things that I would suggest doing, honestly, is when you go in your first couple times when you're going to give this assessment and you get to that follow-up questionnaire, I would bring in these diagrams with you. And literally what I was doing is like checking off, like, oh yeah, he does this, he does this, he does this, as I was interacting with the parent, so that I had kind of that diagram in front of me to kind of follow, and then I went back and kind of scored it all afterwards. So you can do that up front while you're getting yourself acclimated to the questionnaire, and unless you feel really confident that you can walk in and just kind of know the flow and know how to run this. So it would depend on kind of where you're at. All right, so next I'm going to have you watch another cheesy video of the interview.
Okay, Mrs. Harris, so I did just score the MCHAT, and it looks like there's a couple questions on here that do indicate a level of risk, so I just want to follow up and ask you some questions. Is that okay? Yeah. All right, excellent. So the first question is, if you point at something across the room, does Gemma look at it? Not usually. Okay. If you point at something, what does she typically do? Usually she just keeps doing whatever she's doing. Okay, so she ignores you or doesn't look at what you're doing? Yeah. Okay. All right. Let's move on to the next one. Does Gemma show you things by bringing them to you, holding them up for you to see, or not for you to have it, just for to kind of share that interaction? Sometimes. Okay. Tell me more about that. Does she bring things to you, like maybe a picture or a flower?
She brings things to me, like if I need to do something for her, if she needs help with something, then she'll bring something to me.
Okay. But not just for you to look at, like a picture or toy, just to show you, like, look at what I have, kind of thing.
She's brought me pictures before.
Oh, okay. What about a bug or any other blocks or something that she's done or found?
No.
Okay. Is this sometimes just to show you and not necessarily to get help when she does do it?
Not usually.
So usually she wants more help or something from it?
Yeah.
Okay. Alright, let's move on to the next question, just a few more. Does Gemma you in the eye when you're talking to her, when you're playing with her, changing her?
Sometimes.
Okay. Tell me more about that. Is it more when she needs something? She look you in the eye?
If we're playing, she'll just look me in the eye.
Good.
Or something.
That's really good. What about during like feeding, diaper changes?
No.
No, it just kind of keeps to herself. Okay. What about when she needs something?
Sometimes.
Okay. What does she usually do?
No, not usually.
Okay. What about when you guys are reading a book or you're talking to her?
Talking to her, she'll sometimes.
She will? Okay. Good. So if you turn your head to look at something, does Gemma look around to see what you're?
No.
Okay. Would she look if you? What would she do if you?
Sorry, guys.
Do look at something.
Usually just keeps doing whatever she's doing. Does her own thing.
So just kind of ignore what you're doing. She wouldn't notice.
Yeah.
Okay.
Look at your face? If something was loud, maybe. Okay, okay. How if you just looked over at something, would she also maybe look at you? Okay. Alright, this last one. If something new happens, does Jenna look at your face to see how you feel about it? Sometimes maybe. Okay, what about usually? Let's talk about if she hears something strange or scary going on, would she look at you and kind of check in with you? Probably not. Okay. What about when somebody new approaches? No. No? Okay. And does she look at you when she's faced with something really unfamiliar for her in a new environment or something that's new or scary? Does she look at you? No. Okay. All right. Well, let me go ahead and go and score these last few questions that you just answered, and then I'll come back and talk to you about the results. Okay.
Okay, so obviously we went through each one, and again, because this is not something that, I wanted to show you guys like that when you're not fluent in it, you can use those tools, those flow charts. That's what I was using and following as I was going through it and making sure I answered some of those questions. And you can make it even more conversational than that, depending on where you are at in your comfort level with the questionnaire and with the parents and so forth and the information that you're seeking. So when you're scoring that component now, the follow-up component, what you're looking for is if there's 2 or more failed items at that point, you're going to say it's a positive. So that indicates enough of a red flag at that point where you've followed up, there's still a significant level of concern, and then you're going to move forward with the referral process. Again, they need to answer the yes or no. They need to give you a clear distinction. So responding to those sometimes or I'm not sure answers, those things you need to ask more follow-up questions to get more information on, how do they typically respond or what do they do more often. And then if they don't know, then really seeking out, giving them some of those examples that are on the flow charts and, kind of asking some open-ended questions. Well, tell me about a time when they would do that, or tell me what you've seen, or tell me when you've asked them to do this. So here was the actual scoring from the interview portion that we just did. So they failed 4 out of the 5 questions after the follow-ups. Remember, they initially failed 5, and now they have continued to fail 4 out of the 5. So is that still a positive or is that a negative? Still a positive, right? So now we're going to move forward with the evaluation, the recommendations for evaluation and so forth. So before we move on to here, I think it's time we take just a short 5-minute break. Let's take just a quick break, and then we'll come back and we will finish up the results and referrals and everything. There we go. Ah, that's so much better. All right, guys, ready to jump back into it? Are we good on everything? All right, sounds great. All right, well, I hope you enjoyed your short-lived break. We're going to jump back into it and talk about the results and then following up with all the referral and everything, and how do you do that and what are the requirements and so forth for all of that. So as far as when you have that discussion about the results, so now we know that our parent, Mrs. Harris, in our example, has failed now twice, right? She failed the initial questionnaire, we did the follow-up, she's still failing the follow-up, so now we need to discuss those results. Yes?
Do you recommend that the child be present for the pre-screen or for the questionnaire?
Do I recommend that the child is present? I think it would depend on that child and the parent's comfort level with that, and for like some of these follow-up discussions and so forth. So some parents are uncomfortable with having discussions about their child's skill level and skill deficits in front of that child, and if that child is very, I hate to use the term, but high functioning, so they're very cognitively intact, then I probably, may want to talk about or ask the parent permission of like, how do you want to discuss this? But if that child is not able to understand language, or the parent is like, let's just have this conversation, and they're open about it, or they might involve the child in it, all of those things would depend on the parent's comfort level as well with that. Okay. So when you discuss these results, you're going to, again, reiterate that rationale and reiterate what you did and what that questionnaire is. So earlier we had a parent share her story about how when they got those results from their personal evaluation, it was kind of like they drew a blank, right? Because you're getting so much information, and as an emotional barrier, you just kind of sometimes black out with a lot of this information. So it's important to follow up again. Depending on where you guys are at and the types of facilities you're in, you may have been running 5 other tests while you're in between scoring these things. So you want to reiterate, okay, this is the one that we're kind of talking about now. This is why we're here. This is what we're doing. So again, reiterate what the MCHAT is and why it was provided. Again, reiterating those risks and the concerns and the barriers that either you observed or that the parent reported, or both. And then indicating the results. So when you talk about the results, you want to include the level of risk at this point that you've identified. So at this point, we're still continuing to see a level of risk that indicates some risk for autism and some signs of autism. Those red flags, so specifically things that you reported out on that the child could or could not do that indicated risk for autism. And then discussing those specific items like that they failed. So these are the things that you said that, he's not really able to follow a point. You're concerned that he might be deaf. You're concerned about some of these questions. These are the things that we want to do some follow-up assessment on and giving that rationale. And then making the appropriate referrals. Now throughout this, you want to still check in with the parents. Don't just throw all this information at them, because you're still going to get that blank stare, right? And I was actually conducting a presentation yesterday where somebody in the audience shared the same thing, that they were working with a client, and the client went to a doctor and got some referrals for different medications, and called up the clinician and said, I just left the doctor's office. I have no idea why I was given this medication. I'm still unsure of like what's going on. And just, even though it may have been explained to them, again, because we sometimes draw a blank or we don't fully comprehend, or our mind's in 10 different places, and you're getting a lot of new information. So then the clinician helped to follow back up with the doctor and try to figure out what was the medication that was prescribed and why, and kind of assist with that parent in comprehending everything. And the parent ended up walking away. The doctor ended up calling the parent directly and talking to them and giving them some follow-up information, which they said was so helpful to them. So just recognize when we give that information, take it slow, check in often, make sure that they really understand what you are saying, because sometimes people will and they're not really listening. So discuss those failed items. And then make the appropriate referrals from there. So talking about those next steps of what is an evaluation, and what type of evaluation are you going to be getting, and what kinds of things are going to happen next, and who do you call, and what's the next steps in that process. And any additional testing that you may recommend, which we're going to talk about as well. So it might not just be the evaluation for autism, but maybe there's some other red flags as well that need to indicate that you would recommend some further testing. So here's a nice little flow chart for you guys. So again, starting on the left, if there's those negative results, so low or no risk following the follow-up. Again, if the child is less than 24 months, reevaluate after 24 months. Just make this part of like your standard treatment. If you're in a, like for example, a pediatric office or something where you see the clients more frequently. So reevaluate, check in, make sure there's still no level of concern. Some parents do report that right after or right around that age of 2 is where they start seeing concerns, that they may have felt like maybe their child was slightly delayed, or maybe they felt that their child was typically developing, and then they hit that 2-year mark and then they start to see there's some regression, or there start to be noticeable differences where the parent then develops a concern. So even though they passed at 18 months, may not mean that they pass again at 24 months. So it's important to kind of follow back up again if they are under 24 months. If they're over 24 months, but you're still seeing those flags for concern, even though they got a negative on the questionnaire, but you as a clinician are like, oh, something's not right here. Maybe the parent's not accurately reporting, and so I still see concerns here, then you would still want to discuss those concerns with the parent and still move forward with that evaluation and referral. Okay? If there's positive results, though, so if we have that medium to high risk, so on the follow-up, and if they were at the high risk at the initial questionnaire, or if they're at the still at a positive for the follow-up questionnaire, then you would want to discuss that level of risk with the parent, and then discuss what items they were failed, what we just talked about on the previous slide, and then again refer at that point for evaluation and testing. Okay? So let's watch another cheesy video of discussing these results.
Okay, Mrs. Harris, so we just finished scoring the MChat, and we do see that Gemma does have a risk for autism.
I mean, she has autism?
No, she does not have, we don't have a diagnosis of autism right now, okay? So what this means is just that she's at risk for autism, okay? She scored a little bit higher on this evaluation, higher than we would be comfortable with.
How high of a risk is she for autism?
She's considered a medium risk right now. So after the questionnaire, she was at a risk, and then when I did the follow-up questions, she was still a risk. So because of that, we would want to evaluate her for a further evaluation, or recommend her for a further evaluation. That would help to figure out if she actually does meet the criteria for autism by somebody who's certified in providing that diagnosis, okay? So I do have a list of people here that I'm going to give to you, and these are different evaluators in our area, and they can help to see if she's going to meet that criteria or not. And so all I would want you to do is contact one of these providers. You can try to contact multiple, see who you can get in first with or who accepts your insurance. But go ahead and give them a call, and let's start the process. So it can take a little bit for you to get in. The sooner you call, the better off that you'll be, okay? Get in and get something scheduled. What I'd like to do is meet back up with you in about 3 months. And that way we can kind of see if you've had a chance to get into that evaluation, what the results are. And if you haven't gotten in, we can talk about what do we do in the meantime, okay?
Okay.
Have you discussed any services with the school at this time?
No, we haven't.
Okay. Why don't you also make a phone call to the school district? And I also wrote some phone numbers down here as well for your local school district and some people that can help you there as well. And you can start the evaluation process there as well to try to get her into some extra support. She is young enough to kind of benefit from a lot of that.
Okay.
Okay? Do you have any questions for me right now?
No, I don't think so.
Okay. All right, well, there you go. I'll see you back in 3 months, and we'll talk more about it then, and hopefully you guys can make some progress on this evaluation before then.
Okay.
All right, thanks.
Okay. So did anybody catch in that the parent thought initially that this was a diagnosis, right? And so it was really important to catch that and to clarify this is not a diagnostic tool. This is just simply a screener that indicates that there's a risk. And, you know, I always try to clarify I am not a diagnostic professional. That is not what I'm certified to do, what I can do. I won't do, right? I'm not going to label that, but I want to refer you to somebody who is a professional in that and who is certified to do those things. So to help with this, make sure that you stay positive. You know, your tone and how you interact with the parents is so important, because if we kind of, you know, come off as very harsh, or if we come off as very robotic, or I got to get to the next meeting or whatever, those kinds of things can really hurt your rapport with the parents and may hurt their follow through and their trust in the results. So instead, trying to stay positive about, hey, I don't know what this means. You know, this means that there's a risk here right now, and I need you to follow up to figure out, is there actually an appropriate diagnosis, and what is that diagnosis? So this leads us in a couple different directions, and this is what we have, what the information is that we have so far. So try to help them stay positive and try to, you know, I'm not saying to give false hope either. There is a balance there where I'm not saying, oh, I'm sure everything is fine, you know, it'll be great, just go ahead, move forward, because then if that parent actually does get a diagnosis, it may hurt your trust, it may hurt your rapport with them. So you want to be supportive and comforting and empathetic, but at the same time, you know, help support them to go in the right direction to get the proper diagnosis. So validating the parents, you know, depending on where the parents are at and what's going on with how they're coping with this screening. You know, making sure that they understand, you know, I know that this is hard. I know that this is really challenging. Autism and some of these diagnoses that this is screening for are often lifelong diagnoses. These are not often, you know, very light diagnoses. These are pretty serious. And so, and it often means like something significant may be wrong, quote unquote wrong, with my child. So we want to make sure that we are really, again, focusing on the parents' emotions and the parents' reaction to this information and supportive of them. So, so I know this might be hard to answer, or I know this may be hard to hear this information. It can be frustrating to be asked the same question by a different person. Sometimes these, you know, parents have been asked the same types of questions numerous times. You know, and so they are frustrated by the time that they get to you, or frustrated by the time they get to the evaluation, because they, and even more frustrated by the time they get to services, because at that point, I'm sometimes asking them the same things that they have been asked numerous times. So if you're getting that sense, or if they say things to you, or have like a tone that you kind of feel like they're getting frustrated because we've been talking about the same information over and over again, validate. It is frustrating to be asked the same thing over and over again, and I'm not really sure how you answered this before, and unfortunately I have to take the time to ask you some of these same questions, you know, and making sure that you're still getting all the information that you need. Make this interaction really conversational. So tell me about this. You know, ask those open-ended questions. What would you do? What would your child do if this happened? Or could you give me an example of that? Those kind of give the parent the opportunity to talk rather than being talked to. And so those open-ended questions really kind of open up the opportunity for rapport. And then you can follow those things up with highlight statements of the child's strengths and positive attributes. Like, wow, he really knows a lot about that. Or he really seems to enjoy Spider-Man. Or I bet that's really cute when he does that. You know, if it's something that's appropriate. You know, sometimes parents will kind of laugh at some of the atypical things that their children do, or they find humor in them, which it's important to find humor in every day and in life. So you might want to kind of comment on some of those things like, wow, he knows a lot about Star Trek. Wow, Star Wars is something he's really interested in. And that way you can kind of build that rapport and highlight that. Now that doesn't necessarily mean that you are favoring it or complimenting in the same way. And you want it to come off as being really true. You know what I mean? You don't want it to be just a fake statement. You know, you want to really highlight that child's strengths. Some kids have some amazing abilities, even though they may be very cognitively impaired, they still have great strengths. And it's important as the parent is telling you this, because if we're hyper-focusing on, this is what's wrong, this is what's wrong, this is a red flag, this is a red flag, man, as a parent, you're just drained at the end of that. And it's very hard to go through those meetings. But if we can kind of balance that with some positive attributes as well, it does kind of feel a little bit more uplifting in that you recognize the child's strengths as well as the deficits. So let's talk about this example here. You approach a parent, educate them about the MChat. The parent refuses to participate and tells you, my kid is perfectly fine. The parent is acting offended at your request to conduct the MChat. What do you do? What are your guys' thoughts?
You could just
Yeah, so you just,
Normalize it?
yeah, you normalize it, reiterate that we do this with everybody, and this is just kind of standard. Now again, if it is standard in your practice, and that's one reason why it would be great to become standard in just your typical practices, because then you can make those kinds of statements. If you're doing this only when you evaluate risk, you might not want to lie about it, but you may want to talk about if you don't do it as part of your practice, what else might you do? You might want to talk about then, well, these are some things that you reported to us that we want to just be able to kind of clarify and identify. Is there anybody else have any thoughts on how you might respond to this? Do you have a thought?
I might let it go and say, if you are concerned later on, come back and we'll look at it again. I'm not sure if I would push it.
Okay.
This may be the first point of contact that they actually have to look at. I don't think my kid is okay, but I'm not ready to admit it yet.
Yeah, so they might be in denial at that point, and it might be only the first point of contact, so you might just kind of, you have to assess in the moment. Is this the first point of contact? Where are they at in terms of the age of this this tool? And like, are they at 26 months and they're nearing the 30-month age, or are they 15 months, and so you're kind of at the lower end of this tool? So you might validate the parents and say, okay, I understand you're not ready for this. Maybe we can talk about this again next time. Yeah? Yeah.
If you have other resources to give them, like physically,
Yeah.
you might want to have that as one resource just in your packet of things.
Sure.
If you are concerned about this, or if you see this, or if you see this, then you might want to contact, and you might have names besides yourself.
Mm-hmm.
You might want to contact this person or this person or this person, because the earlier we can provide language services,
Mm-hmm.
the more effective we can address the issues.
Yeah, so you're doing a couple things there. You're giving referrals and resources you're giving resources for like just general information about, for example, autism or language delays and things like that. You're giving referrals to other people in case they want to move forward without maybe you being directly involved. And then also you said, there was one last piece that you said there. I'm missing it. I lost it. I'm sorry. Education. Oh, yeah, that's right. You were giving some education about here are some things to look for. Oh, I think I said that one. What is the last piece? Oh, it was so good too.
Information, resources, the paper. You give them a chance to back off.
Okay.
Or you've backed off. You're giving them a chance to look at it at home.
Oh, that's right. Okay, so you're giving them a chance to look at it at home.
With that, I was just thinking that maybe sending them home with the questionnaire too, and
Mm-hmm.
maybe they're not ready at that point, but maybe they kind of have had some thoughts, maybe something is wrong, and if they start looking at it and see what kind of questions they are, then maybe
Yeah.
that's another thing they can either contact another resource or come back and say, I looked at that and now I want to talk about it.
Yeah, so sending them home with the information as well, and sending them home with the questionnaire to fill it on their own terms and mail it back in or bring it back in at their next time. Yep.
I was just thinking, I guess that if they have indicated things that there's a concern, just kind of saying to them, you know what, I know that this isn't something that anybody wants.
Mm-hmm.
I know how much you love your child and you want what's best for them. It's possible that there may not be a concern,
Mm-hmm.
but this is a tool to help us find out if there may be. And what we have found with research is that when these issues are present, that the children have far better outcomes if we're able to catch it early on.
Yeah, so educating them about the outcomes. I mean, you did a lot there in that comment that you made. You kind of did a lot of rapport building and explanation of the rationale of why you're doing this, and as well as the education on the outcomes, which I think you had mentioned before. I think that was the missing piece that I was trying to get at, was the education on the outcomes related to early intervention. So the reason why we're doing this, let's get them some help now, because then the outcome is better if we get them in services now and what those outcomes are. Do you want to add something? No? Okay. All right, very good. So there's a lot of options, right? There is a lot of options on how, and what you would want to do would depend on the parent that you're working with, the level of concern that you have, and the situation that you're in and what the client's age is. Again, if they're nearing the end of this and they're getting older, that might become more of like a sense of urgency to kind of target that client for services. But if they're at the lower end of ages, you might want to, okay, let's try again in 6 months, or can we follow up in 3 months instead of 6 months? So here's some considerations. So validating their concerns. So kind of making them feel like, I understand this is hard for you, right? Having a screener is really challenging, and this could lead to information that could be really hard to accept. So I understand how this could be very emotional for you. Inform them and let them know that this is just a screening tool. It's not necessarily a diagnosis, and your child may score as negative, but it's important for us to look at this a little further and see, are there any risks? Are there anything that we should do to move forward in an appropriate way? And what are those things? Seek information from them. So asking them just some open-ended questions about, do you have any concerns about your child's behavior problems, or do you have any concerns about your child's skill level or development? And asking them even some of those questions verbally, how do you feel about your child's hearing? Does your child follow instructions really well from you? Do they follow point? Do they do some of these things? You can kind of get a sense then of the risk level without actually formally having to do the questionnaire as well. Giving them control. So we don't have to, but we strongly recommend this. So giving them that power and authority back. They are the parent, right? And they don't have to do this in the end. They don't have to follow your recommendations. Even if you get all the way through the process and you recommend the evaluation, they may not choose to follow through. We want to encourage them to, and on our end, we want to be supportive and help them through the process. But at the same time, they don't have to do it, right? And we want to validate that, and we want to give them that control because it is ultimately their decision. Help them ease their anxiety, again, by reinstating that it's not necessarily a diagnostic tool, but just an informative tool to let us know, is there further testing, and what that further testing might be that we need to do to determine some appropriate skills and appropriate services. And then again, if you have gathered enough information at this point that indicates enough of a level of concern, don't feel like you have to have that questionnaire to, verify or to be the end all. If you have enough information that indicates that you have concern from talking to the parent, say, look, we've talked a lot today about, X, Y, and Z, and there are some red flags and there are some concerns, and it would be helpful to do this tool, but even with the information you've given me, I feel like there might be some red flags, so I would still recommend an evaluation if you feel that that's appropriate. Or if you don't feel that that's appropriate, then you might not want to push it very far. If you feel like this child is, developing on track and you don't have those concerns and the parent doesn't have those concerns, then just say, okay, let's try again next time, or we'll see how it goes at the next visit. Okay? Here's another one. So you ask the parent to complete the MChat, and when you receive the completed MChat, you notice that yes has been scored for all responses. My child does everything. What do you do?
Ask them if they read it.
Okay. Ask them if they read it.
Well,
Were you going to say something?
I would guess maybe they can't read, and maybe they were too embarrassed. I would clarify that because sometimes it's embarrassing to say I can't read.
They may not be able to read, right? So their education level would be important, and their comprehension of English. If you're giving them an English tool, do they understand English, right? So definitely, did they read it? Can they read it? Do they understand it? What else? Yeah.
You could maybe point out one of the specific questions that they said yes to. Oh, wow, that's really great that this child can do this. Tell me about it.
Okay, so
maybe prompt them to talk more, and maybe they'll
yeah.
that it's not necessarily true, or it is.
Yeah, so it sounds like you're kind of moving into the follow-up interview section because you're kind of highlighting one of the areas that they responded yes to that they should have responded no to, and you're trying to clarify that, right? So remember, do you remember there's 3 questions that you should respond no to? Do you remember that? Right? So if you respond yes to everything, it's going to flag that there's a risk for autism. Remember? Because you will have 3 no's or 3 yeses that should have been no's. And a 0 to 3, remember, is that there is a risk, or 3 to 5 is that there is a risk of autism, right? So it will flag it. So then at this point, if they're doing this, you would have to do the follow-up interview, okay? But definitely you want to follow up with those questions and give them the opportunity maybe to score it honestly and say, you know, hey, did you get a chance to really review this and read this? I just want to make sure, because there were some things that I was surprised that he scored on or she scored on the way that you had responded. So if you didn't get a chance to really review this, I can come back and have you, you know, really fill this out completely. Or, you know, making sure again that it's, you know, they can read and that it's in their native language and so forth. So if they, if this was truly accurate, though, if they responded yes, this would kind of flag to me if they did respond yes to everything, that maybe the parent is responding somewhat defensively and maybe they're not taking this tool very seriously. So I would want to kind of have some conversations about, like, why did you just respond yes? Is this really accurate? Or is this like you're not wanting to really give me, you know, the right information and fill this out appropriately? So then you would follow up with the interview and so forth if this was truly accurate, or if the parent, you know, was being somewhat resistant. You would want to do the interview, the follow-up interview, and then make the appropriate referrals. So here's another one. After reviewing the positive MCHAT results with Mrs. Hill, she refuses to follow up with an evaluation. She states there's nothing wrong with my child and that she won't follow through with the evaluation or services. She is visibly upset and yelling at the clinician. What do you do? Mad parent.
First of all, not this parent, but but first of all, don't take it personally.
Mm-hmm.
Then you could respond clearly, more, I think more clearly with your answers than, you know, you're taking it back and take it personally.
Yeah.
And stick to the facts.
Yeah. Definitely, good advice. Don't take it personally. I mean, it is hard not to take it personally when you're the kind of the other end of that conversation, but at the same time, as clinicians, we do have to remain professional, and we do have to make sure that, you know, even if we are taking it somewhat personally, we leave that for when we leave the room. So remaining calm, remaining professional when we're working with the parents so that we can actually address their concerns, because it's about them right in that moment, not about us. So, yes, what else?
I would maybe plan to schedule something with her a few days out and say, you know, let's call it good for today.
Mm-hmm.
Why don't we get together? Can we schedule something for next week?
Okay.
We can discuss things further.
Okay, so kind of ending the meeting there, showing like, okay, I can see you're visibly upset right now. Why don't you have time to process this? Let's meet next week and kind of reconvene and talk about this. Yeah, depending on your practice, if you're able to do those kinds of things, you might want to schedule a follow-up and check in after they've had time to digest it. What else? Yeah.
Being sensitive to what the parents' fears are is
Yes.
important. And I would think one of the big fears that you might be able to help reduce is the cost.
Mm-hmm.
Just saying something about what we would like to let you know is that if there is an autism diagnosis, there are some free services.
Mm-hmm.
And we just want to make sure that you're aware of. Not that that is the only concern. There are all sorts of other concerns, but the cost might be coming to mind quickly, and at least if you have something to offer, that might at least make them think, okay, maybe I can take at least one little baby step.
Yeah, so first discussing what are their concerns, and then if cost is one of them, talking about what are the cost of services and the options for services that may be, or for evaluations and so forth, that may be low to no cost or things like that. So definitely their fears is a big piece, because often we react out of anger or frustration when we actually have a different emotion inside. Like, I'm scared, I need to get out of this situation because I'm afraid of the results, I'm afraid of what may happen, I'm afraid of the cost, I'm afraid of the commitment, I'm afraid of everything else I got going on in my life, and now you need me to add something else, right? So there's a lot of potential fears there. So definitely here, that's pretty much exactly what we said here, asking questions about what is their discomfort with the evaluation, what is their their concern or their fears with that. And that may be things like a stigma regarding the diagnosis. You know, maybe we don't know this parent. We don't know this parent's history necessarily, even if we know them, even if they are our client or we're familiar with them. We don't know, you know, that their family members have been talking about them or that their family members have been talking about their child and kind of targeting that child in social interactions and things. So, so they may already have been felt attacked, and now you're bringing this information to light as well. So they could feel very attacked. So that might be their fears about the stigma regarding an autism diagnosis. It might be that they don't see the symptoms that are leading to referral and that they believe that their child is just a slow learner, right? And unfortunately, I think this is kind of an area that's gotten us historically into some trouble with this autism diagnosis, because it's been, you know, 2-year-old boys, right? That's kind of our early intervention age at the young end, and boys. And I can't tell you, I mean, I have a 3.5-year-old daughter, but I've heard so many times, well, boys are just slow learners. Well, she's a girl, she'll potty train fast, but boys potty train slower. And I'm like, what is this genetic difference in, you know, boys versus girls that really people feel makes such a big difference? But, you know, a lot of people say, well, boys talk slower, boys talk later, boys do this later, boys are just generally slower. And that kind of gender identification then can lead us away from an autism diagnosis and early identification and so forth, because then the parents are like, well, I'll just wait a little bit longer. And then you have grandma come in and go, well, you didn't talk till you were 3.5, right? So, and then you're like, oh, everything will be fine. And it kind of helps to ease the parents' concerns a little bit. But at the same time, it kind of leads us away from that early diagnosis and early intervention. So we may want to talk about, well, why is that child a slow learner, and what are the facts versus what is the fictions of those gender learning roles and so forth. Discussing the symptoms that actually are leading to a positive screening at this point. So now we have the results. So we have some data, in other words, that kind of shows us that, well, based on the things that you're reporting, these are concerns that are indicating more than just a slow learner. And we want to make sure that if he is learning at a slower rate, we get him some extra support and assistance so that he can learn at a faster rate and he can catch up with his peers, because I'd hate to see him be held back, and I'd hate to see him not work at his potential because he's, you know, not being able to be fostered where he's at right now while it's early enough. Discussing the treatment options and the prognosis with treatment. So somebody mentioned this earlier, kind of talking about, well, if we do get in, let's say that we take a couple scenarios. If we do get him into early intervention right now and we follow through, get the evaluation, get the screening and so forth, this is what your outcomes would look like now. So he'd be more likely to achieve some of these skills. He would be more likely to make gains in these areas. If we wait, the gap between him and his peers becomes bigger. And so if he doesn't learn these skills right now, because he is a slow learner or because he has an additional diagnosis, that gap becomes bigger, which means that it's going to take a longer time to catch him up, if we're even able to catch him up. So getting him in now gives us a better long-term prognosis. So letting them know that there are different treatment options, and asking them, what do you know about treatment options? Because some people may think, you know, oh, I've heard about ABA and it's terrible and they make kids robots and they do 40 hours of work at the table all day. And you're like, okay, well, let's educate about what ABA really is and what is really the research on that. Or they might hear different things about, you know, speech therapy or OT or different kinds of services, or they may not know what those options are. They may say, I've heard people tell me all the time, well, my school doesn't offer special ed. Like, you mean in your building? Because every school you have to have some level of special ed. So, you know, if they're just unsure, they don't know what those options are. Some people feel that they have to wait until their child is school-aged before they can actually access services. And so they may feel like, oh, well, he's only 2 years old. I mean, he's so young. He doesn't need anything, or there's nothing out there for him anyway. So kind of re-educating them about some of those inaccurate ideals is important, because then they have the truth and they have real information. Now again, it's their choice. They have the power, they have the control, but now they have the right information to make a different decision rather than having inaccurate information to make a decision. Here's another one. A parent scores her son as negative on the MChat. However, while you were working with the family, you noticed hand flapping, spinning, and minimal language for a 21-month-old child. What do you do?
I think you just kind of explained that you noticed other concerns and, sometimes the tool doesn't capture every single concern and that you would still recommend doing more evaluation.
Yeah.
Just to be sure, because it's better to be safe than,
Yeah, so you kind of identify the other concerns that you're noticing, even though they weren't showing up necessarily reported on the MChat. Those are still your skills or your observations and things that the risks that you observed, and that would still cause you to move forward with an evaluation and referrals. Okay, anybody else have any different thoughts other than that? Yeah, what was your thoughts?
Language difficulties are less threatening than autism. And language difficulties are a part of autism.
Mm-hmm.
But given that, you might be able to say, well, a 12-month-old, usually one word at 1 year, 2 words at 2 years is kind of inaccurate. I'm thinking that there might be some things we want to check out on language. So you might want to at least open the door. I don't mean lie, but but that might be a little bit more palatable at first to explore the language, and while you're exploring the language, then start to explore the other things as well.
Okay, so you're saying that giving them some information about typical development in language and then where their child is at in language and comparing those two to kind of demonstrate that there might be some room for risk and there might be some room for concern, just generally concern, not just autism specifically, but then referring them more for services and evaluations on language delays rather than just autism.
And then continuing to observe the other things, maybe opening it up.
Okay, and then continuing to move forward with over time as you see progress or build rapport, then getting them additional diagnoses or additional services.
Or education regarding the other concerns you might have.
Yeah. Yeah, and I think how you respond to this is going to depend on the parent, right? Of course, because you may want to do that for a parent who's only receptive to hearing about a language delay. And if you have a parent who maybe they're not necessarily unreceptive to a language delay or unreceptive to autism, you may want to move forward then with the more accurate diagnosis of autism, right? But if they're only like, nope, it's just a language delay, or I'm only concerned about language, okay, well, let's at least start somewhere because something is better than nothing, and at least getting them that. You may also be able to reach out then to the speech and language therapist and say, hey, these are also observations that I have seen. These are also things that I have recognized and that I need to, we need to kind of collaborate to help. Do you see the same things? You know, how do we work together to work with this family to get them to the right place? You know, because sometimes coming together from multiple people rather than just from one person is important as well, okay? All right, good thoughts, guys. So we had recommended discussing the observations and gathering more information about the level of concern. And then if the concern is high, so through your observations as well as like, you know, your discussions and things, those all go into that, what I'm saying, observation. If you have a high concern, right? So if there's enough concern there, like depending on how severe the language delays really are, maybe it's just poor articulation for a 21-month-old, because it doesn't really specify in this example, but if it's just poor articulation but language is intact and, you know, maybe they do just need some more speech therapy or things like that. Or if you're seeing a lot of concerns, depending on the level of like social delays and language delays, and if you're seeing some of those restrictive and repetitive behaviors of interest, and you have a higher level of concern, then you may want to go directly for that referral and so forth. But if your concern is low, based on your observations and your skills as a clinician, then you may want to just say, you know what, you know, these are still some risks that I want to keep my eye out on. Let's meet again in X date, 3 months, 6 months from now, and let's see if we still have these concerns or how, you know, your son is doing based on time. So let's talk a little bit about false positives, because this is something I've already kind of heard a question about. What do we do in the case with false positives, and how often does it happen? So false positives is something that could happen. A child could come up as being at risk for autism on this screener, but then they go for an evaluation and they don't necessarily get a diagnosis of autism. Remember, this is not just an autism screener, although that's what it's mostly used for. It will capture the developmental delays and the language delays as well. So you may see some kids who don't necessarily get autism but get some of these different diagnoses. I would still move forward with the evaluation. If you do get a screener, this is a validated measure. This is an evidence-based measure, so there is enough of a risk there for us to then say, let's move forward with this. Let's just make sure. I'd rather to move forward and make sure that there's nothing there and feel confident about that by somebody else who has the expertise to actually diagnose than to not do that. Now, there shouldn't be very many of these kids that you get false positives on. That's not going to happen frequently. And especially if you're doing a nice job at kind of helping decipher the questions through the follow-up interview and so forth, there shouldn't be too much that kind of gets through. And remember, you're using your follow-up questions, you're using your observations. Those are all your clinical skills that are helping to make judgment and to helping to kind of finalize this. But if even after that whole process, the observation, the follow-up questions and everything, and there's still a substantial risk, you want to make sure that that child is still getting another set of eyes on them by somebody who may evaluate them and get a more proper diagnosis for them. So even if they don't get a diagnosis necessarily of autism or of one of these other areas, the language or the developmental delays, then you still get some information though about what has been ruled out. So then you still know, okay, why do we still have these risks? Why do we still have these concerns if they don't meet the criteria for autism and they don't meet the criteria for a language or a developmental delay? What else is going on that's impacting this child's learning and causing them to have these types of symptoms and behaviors? That's going to lead us to other questions, and maybe some of that will be evaluated in the evaluation as well. Maybe the client will have something like ADD or ADHD that's impacting their ability to follow points and attend to people and have some of these social skills and engage in restrictive repetitive behaviors. So maybe there's some additional information that we can still get from that evaluation even if they don't have an autism diagnosis. And that's again why it's so important not to diagnose them at the screening point and not to say, oh, you know, this means that there's a diagnosis of autism, because it doesn't. Any questions on the false positives or even anything we've talked to up to this point? No? Okay. All right, so here's kind of a nice little visual of where we've come so far and where we're at and the process that these parents are going through. So somebody has concerns, whether it's the parent brings those to you or you bring them to the parent. You then move forward with your screening tool. Your screening tool is then going to lead you to for recommendations for an evaluation, which is then going to move them into treatment. And then from there, you should get progress, okay? Now, this is a pretty long timeline. By the time that parents get to my doorstep, they are usually exhausted. And I've had parents say to me, like, when am I gonna start services? And I'm like, well, I can get you on my schedule next week. And they're like, next week? I was hoping to like start a month ago. Like, they are ready to go because they have gone through months of waiting and through the evaluation and the screening process, et cetera, and they're done, right? And we saw that a lot, especially when the autism insurance first went through, and you had all these parents that were like waiting for the law to pass, right? And then that law passed, and they were like on the phone, and we had backup waiting lists everywhere. And the waiting lists weren't entirely accurate because you had parents that were signed up at multiple centers. And then they would get in at one center, but they were still on our waiting list, not knowing that they got in over here. So we were like, okay, our waiting lists are 6 months, but really it was not necessarily because, you know, we didn't have an accurate list. You can't always keep an accurate list of those things. But either way, you know, we do have still somewhat of a bottleneck. There's still somewhat of a delay to get in for evaluations. It's not something that you just call up tomorrow and get in. There's a waiting period, usually of a couple months before you can get one of these evaluations. So I want to kind of have a moment where we talk about how when we make these kinds of referrals, I want you guys to feel confident in your referral. I want you to feel like at that point, like you know that there are risks. You know that you're making the right decision by referring them. And even if they don't come out with autism necessarily, you still have more information than what they have right now. So I want you to think about the earlier that they get in, the more you can impact treatment. And you can really impact treatment by making that referral. If we don't make that referral and we don't at least give the parents the knowledge and the information, then, and even if it's up to them to move forward with it, but if we don't give them that, we're doing them an injustice. Because then they don't have the right information and the right tools and resources to be able to move forward when they're ready to move forward, right? So we need to really make sure that on our end, we're doing the right things to make sure that that child is getting as far as they can with treatment. Your knowledge of autism signs and symptoms. So it's really important for you guys to be aware of what does autism look like. It sounded like all of you guys had some exposure to autism, at least in this room, and so that's great. And we talked about that different spectrum and what some of those different skills and characteristics look like. But autism is very different, and continuing to educate yourself constantly about what that looks like and what that looks like per each kid, because it's so different. And the more we can give ourselves knowledge, the more we can kind of decipher when the parent tells us something that doesn't sound like your typical profile, but we may be able to identify it as being still on the spectrum because of our experience and exposure. It kind of bothers me when people kind of have this idea when you say autism. So many people think of like Rain Man, and they think of kids who can just like savants that can just know numbers and count things like crazy. I'm still yet to meet one of those kids, or they think of things like the kid who is very socially deprived and just stays in a corner and rocks in a corner. I kind of get like these two very different, like, oh, those are the kids that you work with. I'm like, not really. I mean, I have had, kids that are highly intelligent and can do things that are amazing for their age or for the rest of their skill set. And I've had kids that are extremely impaired, but I've never had only this or that. It's kind of this giant mix. And so the more that you can even educate the community about what autism is so important, because then people will be able to identify it more and be able to kind of talk about it more at an informative level. So your knowledge of evaluators, and we're going to talk about that today and how to kind of seek out and navigate that system of evaluations, because your knowledge of evaluators is important to know who are reputable evaluators, who to send the person to. There's only certain types of evaluators that can evaluate for certain insurances and so forth. And if you're sending them to the wrong type of evaluator, it's going to be a waste of their time and money. And we don't want to do that. We want to make sure they're going to the right place and the right people. Knowledge of treatment options and research. So again, I have had many families who have I've met people even that have a very inaccurate idea of certain types of therapies like ABA or even speech therapy. They kind of have this idea that either they're going to fix everything or that they're terrible. And sometimes that comes from somebody else that they knew that had a certain experience. And there's bad clinicians out there at every level within every domain, right? I've had doctors that I've absolutely hated. That doesn't mean all doctors are terrible and I'll never go to one again. That just means I had a bad experience. So, it's the same thing with some of these other clinicians as well. ABA, OT, speech therapy, neurology, etc. You're going to hit good ones and you're going to hit bad ones. And so it's important to educate people about, like, well, what was your experience with that? And why are you not really liking that? And yes, there's also not always a good fit. Another important piece of this, though, is what is evidence-based? What are actually research-based types of treatments? Because there are 1,000,001 treatments out there. And I've had parents come to me saying they're going to Dan doctor, saying they're going to horse therapy, they're doing chelation, they have a hyperbaric chamber in their basement. I've had parents that have done... You're going to do everything. You are going to do and I don't blame parents for doing those things, because I agree. As a parent, you are going to do everything that you can for your child. As long as that child is not hurt in the end, you're like, it might work. It might help something. I'm going to do it. How much money does it cost? I'll find a way. And so I'm not blaming any parent, but as clinicians, we need to educate the parents about what is evidence-based so that they're not wasting their time and their money and their resources. I've also run into things where a parent is doing a therapy that's not evidence-based and isn't seeing a lot of, product from it, but they're continuing to do it because they feel like they have to do everything. And then they're using time and money on that could be used on a more effective treatment. So it's important to help them make and understand the decisions that they're making and how that is impacting or impeding or helping their child's progress. So this ASAT website here informs not only parents but also you guys as clinicians about all the different options of treatments and what is the evidence-based research out there on those different options. So it's something that I've used to refer parents to. It's also something I've referenced or referred to other teachers or clinicians so that when they make these referrals, because sometimes I'll hear, oh, I went to such and such therapy because his teacher mentioned that she had a student that it worked for, so I tried it. Okay, so I want to kind of educate kind of the whole community then on what are evidence-based methods and what are going to be the things that if we put our time and money into these things, these are the things that are most likely to make the biggest impact in treatment. Our knowledge of the AAP recommendations, the American Academy of Pediatrics. So I'm going to get to that later on today as well, and that will be one of the emails that you get as well as an article with those recommendations for autism. But knowing what those recommendations are will also help you make appropriate recommendations for treatment that will get them to the right types of treatment. And then another referral option is additional tests and evaluations. So we're going to talk about what some of those are as well. So here is the AAP recommendations. Again, I'm not going to go through all of this, and I will, there's this link up at the top. You can follow that link, or like I said, I will get you guys the actual article that kind of discusses all of these different recommendations. But it is important to think about what is the AAP recommending and how do we recommend treatments that follow those kinds of guidelines. So there's multiple components. I mean, every component in here is so important, but things like low student-teacher ratio, inclusion of family component, entry into intervention as soon as a diagnosis is made or when a diagnosis is seriously considered, rather than waiting until a definitive diagnosis is made. So there's times where we've recommended like this child get into early on services through the school while we're waiting for like the actual insurance evaluation to get into ABA. So getting them more support and more services of treatment, at least 25 hours per week, 12 months a year of a systematically planned, developmentally appropriate educational activities designed to address identified objectives. So these are the recommendations that are made and that we should follow the treatments that follow these recommendations. So treatments that are outside of these guidelines may be less effective. And if you look at, speech, OT, and ABA are the three therapies that are covered under the autism benefit right now, under the autism insurance benefit. And so as the reason why those three are covered is because those are the three that have the strongest research support to make progress and gains with children with autism, and they follow these recommendations as well. So it's really important to think about that and be able to apply this and talk to the parents about when they're doing something different that is not evidence-based, how do we bring it back to what the research supports? So there's two different types of clients. You have your private insurance and your Medicaid. And the only reason why I'm separating them by any means in those two categories is because the evaluation processes are completely different for those two clients. And you have to know what type of insurance are they in order to be able to refer them to the right avenue to get the right services and meet the right criteria for their insurance to accept their evaluations. So starting with private insurance recommends, or requires an autism and evaluation center, an approved autism evaluation center, to complete all three components of their evaluation. And so these are Blue Cross specific requirements, which is why I kept the link there. But what they require is that the autism approved evaluation center has to be part of a academic medical center or a hospital-based facility that is in their network. So it's usually something that's affiliated like the DMC or I think in this, I don't know this area very well. I went to Western in Kalamazoo. So we had like Borges and Bronson over there. I don't know what hospital systems you guys have over here.
Like Helen DeVos.
Wisconsin.
Helen DeVos, okay. So it has to be something that is affiliated with the university and that is a sound medical center, not just, kind of one that's a standalone independent center. The AAC must use a multidisciplinary approach by specialists with significant experience diagnosing and treating autism. So these are people who are specialized. Now, one of the concerns has been in the community is, are kids just getting this diagnosis overly? Are they overly being diagnosed, right? And that has been a concern in the past. I've read reports from people that literally saw the kid for about 5 minutes and were like, yep, this kid has autism. And I'm getting this report. And it's like, wait a minute, how do you know for sure that this child really has autism? So part of these people that are significantly experienced and experts in this are using expert-based tools. One of the things that is typically either required or strongly recommended is the ADOS or the ADIR. If you're not familiar with those, the ADIR is the Autism Diagnostic Interview Revised, and that's an interview of structured questions with the parents that specifically look for symptoms and characteristics of autism. The ADOS is the Autism Diagnostic Observation Scale, and that is a structured observation where there's 4 different types of it. It's like 4 different, they call it modules. So 4 different options of the test depending on the child's skill level, language abilities, and age, and they consider which test option to do. And so the higher levels will be like for really social or older kids or older adults where they'll have more conversation things where it'll be like, tell me what makes a friend. And the child will have to say certain qualities and certain things. At the lower skill level, it's more like play-based. And so they'll set up specific play interactions where it's like, oh, it's the baby's birthday party. Let's set up a birthday party for the baby. Here's the Play-Doh cake, and let's put candles on the cake. And there's a lot of pretend play things, and you expect the child to engage in that interaction in a certain way. And the experienced clinician is looking for certain symptoms and social skill deficits and language deficits that would indicate that they don't know how to engage in that interaction in a certain way. So it's specifically programmed, and then they measure how much qualities did the child engage in, or how many opportunities did the child miss to get a diagnosis of autism. So those skilled, experienced people will be familiar with those kind of tools and rely on those kind of tools to gain a diagnosis of autism. These specialists must include either a board-certified pediatrician, a developmental pediatrician, or a pediatric neurologist. So in our team, through the DMC, we have a pediatric neurologist that would fulfill that requirement, a fully licensed pediatrician neuropsychologist, a board-certified child psychiatrist, or a fully licensed child psychologist. So again, in our team, we have a fully licensed child psychologist who does all the testing and oversees the testing. And then they also require a speech and language therapist. So they need 3 of those team members. They each do their separate evaluations, and then they have a meeting where they review the results that they've all come up with, and they all have to agree that this child has a diagnosis of autism in order to actually qualify. So now you're getting a much more well-rounded perspective. You're less likely to get overdiagnosis, and hopefully less likely to get underdiagnosis as well, and more likely to get an appropriate, accurate diagnosis, which is really what we would like, right? So we're moving in that right direction, and this is what's required as part of that new autism insurance requirements and so forth as far as the laws. Now, Medicaid has a little bit of a different system and requirements, and what I did here, actually let me go back for just a second. I just want to comment and say that right now private insurance only sees kids up to, it depends on the insurance. I've worked with some insurances that say up to the child's 18th birthday and some insurances that say up to the child's 19th birthday. So somewhere in that last year, there's some discrepancy. However, there's a little bit more push right now there's kind of the stipulation that says 18 unless it's deemed medically necessary, right? So we're trying to push right now for some of those older kids to be required, that it is medically necessary for some of these clients who are, for example, 25, 26, to continue to have services. So, but that may not be the case for everybody. So I say that with caution. But I just want to warn you, at least up until their 18th or 19th birthday, depending on the insurance. Medicaid has surpassed us, though, and Medicaid is actually allowing up to age 21, which is wonderful that at least we have a little bit of a bigger gap there and a longer stretch and opportunity for services there. Now, if you follow this map, and you can follow this link to get to this map, but you basically click on your county, and then your county, there's different links on there for who do you contact for your evaluations and who do you contact to go through the process and everything. So you may have to sit down with the parents sometimes and actually go through these things with them. Medicaid is a super complex system. I don't know how people get through the system sometimes, because it's just, there's so many doors and barriers. And I mean, once you actually get in and you have like a case manager and a supports coordinator, it's a little bit easier to navigate, but getting that far is often very challenging. And so you may want to really do this with your parents and kind of help them and be patient with them and navigate the system with them to be a support system to them, so that you can feel frustrated with them because it is challenging. So, but at least you can start with this link and this this chart here, this map, that will help you at least get some phone numbers and some contact information for the evaluations. Medicaid, I believe, at least the Medicaid in the counties that I've worked with, has only required an ADOS, which is the interactive one that I mentioned, but I don't know if that's true for all counties across Michigan, what they are requiring. So there are some additional testing as well that may be recommended that you guys may want to recommend. Here are some really common ones from the CDC. Audiological testing. So I mentioned before, many kids often look or seem like they're hearing impaired. So getting their audio tested would be important to make sure and kind of rule that out, because maybe there is a hearing impairment, or maybe, depending on the level of significance of that, maybe it's autism plus a hearing impairment. Many kids often have multiple diagnoses. Genetic testing is also really common. Many kids will want to rule out that they have Fragile X or Rett syndrome. Rett syndrome and Fragile X are under the main category of developmental disabilities, and so they have overlapping characteristics of autism, similar to autism, but they have a clear genetic basis where they've actually found the right genes and so forth, and so their treatment may look very different depending on if they have those diagnoses or not. And then there may be other issues that we have found. So I have had many kids who have chromosomal abnormalities in addition to autism. And then the genetic testing, or if you're leading them to like a neurologist, those people may be able to also identify other diagnoses that the child may have, like seizure disorders are very common with kids with autism. Tourette's is very common with kids with autism. There's a whole host of similar disabilities that overlap. And so it's really important to make sure that we're ruling out and we're identifying if there's anything else we need to know about that could impact this child's prognosis, this child's treatment options, etc. Even things like medications. Metabolic testing is testing for like oxygen levels. And I've never had a client who's this has actually been a recommendation. So I've never seen this move forward, but this was something that the CDC recommended, was a frequent recommendation. So maybe that's something that throughout Michigan and other states have been recommended. And then another recommendation may be things like medication management. So for kids who have inattentiveness, ADHD medication is often recommended. Again, if there's some of these other comorbid diagnoses, then there might be medication management for things like seizures or ADHD and things like that. Medication is often used for kids with severe problem behaviors as well. So maybe problem behaviors are very common in children with autism, even though it's not a defining characteristic of autism. So not every kid has problem behaviors, but it frequently happens. So many times our clients are on like Referral or some additional medications to manage their behaviors. And so lastly, here are some of your resources. Kind of separated this into two sections. So on the left, there are resources that I've used like to create this PowerPoint and things that you would use as a reference tool to educate yourself about the MCHAT. You may from there still recommend some of these for your parents, but those would be more for you. And then here would be some additional recommendations for the actual client. So Autism Speaks is a national organization that really looks at autism and provides a lot of education and information, resources, referral information, etc. So there is a list of evaluators and service providers that you can look at on there, and it's separated out like per state. And so they would be able to get some information about where do I now go for treatment, where do I now seek the next step. Their local school district is another client resource that you would want to point them to, because that is a resource that's full of additional resources. So school psychologists and school social workers are typically really informed about the resources in the community, and not only what the school can provide, but what's also offered like in that area. And so that might be something really good for them to tag into, and getting access to early on services. Early on services are before their age of 5, so that they can get some additional support before they actually enter school age treatment. And then the Autism Alliance of Michigan is a Michigan-based organization, and again, another just really good resource site. I've had parents call them up and just ask them questions. They have a really good list of advocates and special education lawyers and just resources for questions and common issues that parents with autism speak, providers in Michigan. They're just a really good link to kind of hone into and be able to navigate, resources in Michigan from. So talking a little bit about coordination of care and follow-up on this. So on our end, it's our responsibility to help guide these parents, right? Because again, if you put yourself in the parent's shoes, you're going to feel pretty lost. And some of us have better skills and abilities to cope with these kinds of stress levels and diagnoses and things, and are very persistent, like our mom here pointed out. Like, that's amazing. But not every parent has those skills and abilities. They're not that persistent. They may not have the education, or this may be like they may not be native to America. So they may be coming from a different country and are trying to navigate a whole new country in a different language, and all that comes along with all of that. So it's really our role to offer that support and assistance to them, and be that support and guidance to them, that non-judgmental support to them. Helping them with ongoing coordination. So helping them through each step. I remember I had a client who was aging out of private insurance, and the mom was like, what am I going to do? And what am I going to do when my client is 30, 50 years old and I'm gone? And she didn't know what that future life was going to bring, and it brought a lot of stress to mom. And her and I sat down, and week by week we kind of filled out like the SSI application, and we helped her apply for Social Security disability, and we helped her navigate that system for ongoing supports, because by her aging out of services, that meant she was going to lose my support very soon. And knowing that timeline was coming to an end, I needed to get her to the next step. And so we did that together, and at the end, mom was so grateful. She was so thankful of that, having that next step of support. She was so grateful that she had some extra SSI income, because that was a big stressor to her of how was she going to get her child to independence, and how was she going to help, build up this life for her in the future. So I helped her kind of with that ongoing, and then moving her into the next stage of another support system that can help her with ongoing coordination. Documenting reminders to follow up at the next appointment. So documenting for yourself. Like, I use my planner like crazy for things like this. And if I have a parent meeting and I say, okay, next time we're gonna go over this, this, and that, I flip to my next appointment and I write it right in my calendar. I'm like, next time we're going over this, this, and that, so I don't forget. I also do formal documentation of progress notes and supervision notes right on my computer. And then when I go to the next meeting, I open up the previous meeting's notes, so I know this is what we discussed, this is where we left off, this is what your homework was, where are we at? And doing those kinds of things to document for you. In our system, we have very open communication with the parents. So I share my supervision notes with the parents. So I encourage them to bring a notebook with them, and I try to be like, let's bring the same notebook every week. Let's use the same thing so you have that one system for yourself, and helping them get organized and stay on top of that. But then I also send them my notes, and I encourage them to review those as well, so that way next week or next time I meet with them, we're on the same page of, this is my interpretation of our meeting, this was your interpretation of our meeting, are we agreeing, or did I hear something different? Having the evaluating agency contact the family. So contacting the evaluating agency and letting them know, I have a referral for you. This client needs to seek services, this client needs to seek an evaluation, and this is what I've recommended for them and so forth. So I've given them your information, but can you reach out and contact them as well? And kind of helping to close that gap, because we all know we're busy, right? We all know, I mean, I had to hire a landscaper. It took me like 3 weeks. So, I mean, just to get into services and so forth, but the longer we wait, the longer the delay is for actually getting into services, because again, there's a waiting list. So having the evaluating agency contact the family as well, and you could let the family know at your last meeting with them that that's something that you're going to ask the evaluating agency to do. So it would be on them if they actually followed up with that, but you could at least reach out and make those attempts. Help to coordinate emails or communication between the team. So for me, again, we have pretty open communication. I like to include the parents in on everything. And it makes holds everybody to a level of professionalism then too. And so then I'll reach out to our neurologist that's in our system, and I'll say, hey, so I have a parent that's coming in. The parent is on this email, so-and-so meet so-and-so. I would like to set up a meeting with this parent, or this is my concern, this is what we've discussed. We've discussed this medication option or this or that. You know, they're gonna be coming and seeing you on this date. Do you have any questions about this client? And, you know, including everybody, doing the same thing with the school. Any contact I have with the school, I include the parent on that contact to make sure we're all in the same bubble. And reaching out to them and making sure that they're doing everything. Now, I do not want to take all the responsibility and control away from the parent. So that is something important to balance. But at the same time, again, we're offering an additional level of support. So a lot of times I'll say to the parents, okay, I want you to follow up in your IEP meeting, and I'm going to email them, and then we'll talk next meeting and see what's going on, okay? So I still want to give them that authority and that control, because lifelong, they're the ones that have to manage this, not me. Request and send follow-up documentation from the evaluator or the treatment provider. So sending it directly to them again and saying, how did your meeting go? So I know you met with Mrs. So-and-so on this date. You know, do you have documents that you could send me, your notes from that meeting, or et cetera? This is what Mrs. So-and-so said about that meeting. What was your perspective of that meeting? So, in sum, I know you guys are getting restless, time to kind of get going, but so early screening does lead to early diagnosis and then therefore to early treatment. If we're following those AAP recommendations, we'll be able to screen earlier at those recommended timelines using the MCHAT, which we know is a validated measure. And we can then get more appropriate diagnostics, and then leading to better treatment options and earlier treatment options for these clients to get a better prognosis. That's really improving, again, the client's quality of life, the whole family's quality of life, and then again, long-term, the amount of services and things that they need for lifelong supports. The MCHAT is used as that screening tool and then can help you make the appropriate referrals and recommendations, but it's so important on our end to continue to do that follow-up, continue to be that support, continue to check in with the parents, ask them how it's going, see what's going on. Don't just like check it off and say MCHAT complete, bye-bye. You know, follow up and see what was the barriers. Oh, that place didn't call you back? Well, let's try it again. Let's try this place. Let me contact them. Let me help you. Let's do it together. Let's take this meeting right now and do it. The more that you can do those additional things, the family will feel supported. It will build your rapport and your trust, and you'll actually get to the results that you're looking for, which is into treatment. So it's really, really, really important to help the families. Here are some additional resources and references. These are the ones that I've used throughout the PowerPoint. I did want to point out references and publications, so if you're looking for some research on the MCHAT, and then MCHAT translations is also a really important tool as well for you. So if you do have families that are not native English speakers, then that might be something important for you to check into. And that is all. Does anybody have any other last minute questions or comments? No? Well, thank you guys so much for your time today. I hope you guys feel that you learned something and, walked away with some information. And again, those emails will be coming to you with the manual and the questionnaires, and you can also find them at those links that I provided to you. Thank you guys for coming.
I have a couple of words for all of you from parents. Thank you. Because you are a lifeline many, many times. And so if I could have you evaluated, I'll do doodle duty. Thank you.
Thanks, guys. Thank you.
I didn't get any questions from the offsite. so
Okay, good.
They were supposed to